If you're going to use the vent with flow triggering, so for most transports and intubated patients, you'll want to have the vent, switch the vent to flow trigger. You need to actually have the flow sensor plugged in, otherwise it's alarming. It's trying to read a volume and it can't unless the flow sensor is in line. As far as setting up the vent, everything you did before, set the flow, set the max pressure for your PIP, your PEEP, your rate, your I time, everything is exactly the same. The only thing we're adding is sensitivity. Sensitivity can go from 1 being the lowest and easiest to trigger. So now the patient is actually triggering the vent. And you can look right here at this space where it shows you what's going on. Control, the vent is cycling at a rate of 30. If the patient actually triggers, you see assist, assist. So flow triggering can be adjusted from 1 to up to 20. 20 is not so sensitive. It takes a lot more effort for the patient to trigger. Where this is set is really dependent on how much leak you have. If you don't have any leak, you can set this down to say 1, 2, or 3. You typically want it as easy as possible for the patient to trigger, but not auto cycle. Everybody wants to know where to set the flow triggering. There's no real magic number. You want to set it as low as possible, but it really depends on how much leak there is. If I actually have a leak, you can see, alarm quiet. I need to raise that sensitivity till it's not auto cycling. If it auto cycles at 7 in this case, what I want to do is not go up just 1 because you're probably right on the edge, go up 2. So now I'm at 9, and now you can see it's just as sensitive as it was before. This is really, like I said, all dependent on the leak. One of the problems with transports is typically when the transport team is going to pick up a patient at a referral hospital, they probably don't intubate that often, and lo and behold, you get there and the tube has a giant leak because they got a 2.5 tube and a 3.5 kid. So you got a big leak. Most of the time, as long as the patient's being ventilated, you wouldn't change that tube out in the field. You'll wait till you get back. Obviously, if the leak is so big that you can't even ventilate the baby, then you're going to have to change it. But you may have to go up high on your sensitivity. One of the things is we don't show leak percentage on this vent. So if I turn off this leak, if I can dial the sensitivity down to say 1, 2, or 3, you pretty much don't have a leak. Now, when you have the flow sensor in and you look at these alarms screen, see alarm 1, now we have a rate, and so the middle column on rate is going to show you your actual rate, and you can set alarms around that. The middle column on volume is actually showing your tidal volume for each breath. In this case, I'm getting, say, 14. As long as I can dial, like I said, we don't show a leak percentage like some of the ICU vents do. They show a leak percentage. One thing that's kind of important to talk about leaks is how are those vents showing leak percentage. What they're doing is they're measuring the flow that goes past the sensor, then they measure the flow that comes back, and they do the math and say 50% leak. Well, it's important to think about this gas that's going past. if there's a leak around the ET tube here and I send gas to the patient, some of that gas leaks away, the patient doesn't get it. If the patient exhales and on the way back it leaks around the ET tube, then I can't measure it with the sensor. So in that case, the patient got the gas, but we can't measure it. So the bottom line is, even with high dollar ICU vent, anytime you have a leak around the ET tube, you really don't know what the patient's getting. So in our case, if I actually turned that leak before I was getting 14, and if I have to dial this flow up to 9, let's take a look at what our volumes are. Instead of 14, I'm only getting 8. So it's really important to keep this in mind. You know, it's kind of a natural thing that the physicians may say, hey, what kind of volumes are you getting when you put this patient on the vent? Before you blurt this number out, 8, what I would do is, make sure that you know whether you have a leak or not. And since I'm above 3, I do have a leak. So before I would blurt out that number, I would say, well, we have a good heart rate, we have a good SAT, but we have a big leak and I'm only getting 8, 7.9. So that way, hopefully they're not going to just think that they need to get 14, because they might dial that pressure up. And so anyway, keep that in mind in reference to leaks. For more products and information, please visit our website at www.biomeddevices.com.